Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
Good morning and welcome to another Saturday Health Hour. I'd like to welcome you to our speaker this morning. It's a consultant obstetrician and gynecologist, Loretta Ogboro-Okor. She works in Rotherham Hospital in Sheffield, and she's going to be talking to us this morning about a problem that I know affects many women, and hopefully she can dispel some of those myths or tell us how to manage this better. And it's about pelvic floor problems, incontinence, and prolapse. So without much further ado, I'll hand you over to Loretta. Thank you, Loretta.
Thank you very much, and good morning, everybody. Without further ado, let's just go straight to what we're talking about today. Can we see my slides?
Yes, we can.
Thank you. Pelvic floor dysfunction, incontinence, and management of prolapse. Suffice it to say that these are each big topics on their own, but I'm just going to have a whiz through it, and I will expect people to ask me questions so that can generate more discourse and make me even touch on places that I may have omitted. We need to demystify the secrets of what's below our waist. And so much so in the Afro-Caribbean society. I was almost going to put this what's below our necks, because for us, once things are down below, we don't really want to talk about them. Generally, worldwide, there is an embarrassment, of course, to talk about anything down below. But it's a lot more worse in our culture, and there's evidence to show that. When you talk about pelvic floor dysfunctions, and management of prolapse, what should come to mind is that you want to improve the quality of life. That's what it's all about. Because all of these problems actually impair the quality of life of the individual. And when the quality of life of an individual is impaired, they can't do what they've always done. They can't have joy, what they've always had joy in. So because I'm majorly an obstetrician and gynecologist, I'm going to dwell more on the female aspect of it. But now and again, I'm going to also talk about where it affects men. However, for those in the core specialty of men, it may be the urologist who would throw the best insight. So what's the pelvic floor? Like the name implies, it's a floor. It's a kind of support. And nature is so brilliant that it's put together a team of bones, your hip bone, right round that waist area, coming towards the spine. And then it thought about it. How do I support this? And said, okay, I'll use a combination of ligaments and muscles to create a floor. That's what it is actually. And you can see the picture here. For males and females, this is what it looks like from the top. Now, obviously, there are the fancy names of all the muscles, which I'm not going to go into because I've been on this program before, and the key is to keep it simple. But these big Latin names and all of that, they're just telling you about the different muscles, the puborectalis, you know, all of these different muscles and how they fit into the spine and the bones of the hip and all of that. But to keep it simple, just visualize that this is like a sling. Think of it as a hammock. And it's going to hold up a lot of things. It's going to hold up our pelvic organs. Think of it that way, and that just simplifies it. Now, again, visualize in the male and in the female. That hammock is what you see. If you can see my cursor, now you can see that hammock, those group of pelvic floor muscles. But then they're holding up a few organs there, the bladder, they're holding up the vagina in the female, they're holding up the lower parts of the guts, which is the rectum, the intestine, and they're holding up the womb in the female. In the male, this same muscle, you can see the sling again. It's moving from the front to the back. This is a cut-through section. Imagine you are stood in front of the mirror and there's a cut-through section right in the middle. And you're looking at the two halves. So you can see that muscle again, that sling, holding up all of these structures. It's holding up the bladder and the bowel, and you can see it. But what's missing in this case now is that there is no uterus, which was the case in the female. So what happens? The female pelvic organ, when it prolapses, it simply, or any organ at all, when any organ prolapses, it simply means that the organ is beginning to slip out from whatever support is holding it. So, and this can happen anywhere. There's a descent of that organ. In the pelvic floor area, it simply means that the bladder or the rectum, it's coming out from where it should normally be, where it should be held up by that hammock. And there's a popular name of one of the top muscles that works. That's the levator ani muscle. Sorry, I just want to. The levator ani muscle. So the question now is, what are the causes of pelvic organ prolapse? Why would that organ just decide that now I want to slip from my usual anatomical position and I just want to come out where I shouldn't? And research has shown that about 50% of women would likely have some sort of prolapse in their lifetime, a sort of herniation. And we have certain causes that predisposes us to it. I could group them into big headings, but look at it this way. Anything that causes a weakness of those muscles that are holding that hammock up is going to cause a prolapse. Anything that increases the pressure on any of those organs from inside is also going to cause a sort of prolapse. So if you have used those muscles a lot, or if there is something that is causing the integrity of those muscles not to be as supple and as firm as they should be, then that thing can definitely result in a prolapse. So just to think about it, if there is too much weight on those muscles, which can happen in pregnancy and repeated pregnancy, so it stands to reason that the more pregnant we are in our reproductive lifetime, the more prone we will become to having prolapse. Increasing age, the muscles will start losing their integrity. Are we big in ourselves? Are we carrying a lot of fat mass? Raised BMI over 25? Or are there those things that will increase the intra-abdominal pressure and put pressure on those muscles? Things like when we have chronic coughing, are we smoking? Are we asthmatic? Are we often constipated and we strain? Where do we work? Do we stand for long periods? Are we involved in heavy lifting? How do we lift? How do we do the manual handling? If you think, but I'm really trying to simplify this here and avoid all the big medical terms. So if you think about it, think about a balance. You want to balance that hammock. You want the pressure on top to be equal to the pressure below. So anything at all that is going to cause all of these, are you gardening? Are you often working with heavy duty machinery and lifting things onto them? Are you doing high impact sports like when you run all the time? People think surprisingly that athletes should not have any of these problems because their muscles are toned. But on the contrary, sometimes they actually exert a lot of force from the internal, and then you find out that they are putting a lot of pressure on these organs and they can also suffer prolapse. So those are some of the causes and risk factors for prolapse. Did you have difficult deliveries? Were they big babies? Anything at all that is going to impact on the consistency of that pelvic floor. Importantly as well, I talked about the suppleness of our tissues. So are there those things that are beginning to impair on the consistency of the suppleness of our tissues? Like when you withdraw estrogen from circulation, i.e. in the menopause, either normal menopause or premature menopause, then you find that the suppleness of the tissues are gone, and these organs start to prolapse. The symptoms of pelvic floor organ prolapse. Women will come to you and say, oh, I've been feeling a dragging sensation down below. Or some will come to you and say, oh, I feel a bulge somewhere down below. Or some will tell you that when I go and wee-wee, it feels like the wee-wee is still there. There's still something there. Some people may complain that their partners are complaining that there is something obstructing them at, especially penetration at intercourse. And some people may have no symptoms. It may just be incidental findings. And in the more dramatic ones, you just find that there is something in between the legs. Okay? But generally, I've put the symptoms up here. And it's important to know that it will vary from person to person, or it will also vary depending on activity. If you are someone who loves to blow the trumpet, just think about it. Each time you go for your music sessions, you may begin to feel that bulge down below. Or if you are gardening, you may begin to feel that bulge down below. Or in pregnancy most times. So anything or any period where the intra-abdominal pressure is raised, especially in women, in this case. Now we have this simple illustration here, types of organ prolapse. So I've talked of the uterus in women, the bladder is in front, the back passage is at the back. Now, if you take a careful look at the diagram on the screen, you are going to see the coloration. The bladder is yellow, the uterus is pink, and the rectum is brown. Now, when there is a push of the bladder into the wall of the vagina from in front, that is called a cystocele, but it simply means that the bladder is pushing into the vaginal wall. Then it could be that the back passage, this is where constipation comes in now. When you are often constipated, you find out that later the back passage begins to push into the vaginal wall as well. So if you look at this diagram, if you can see my cursor here, they are trying to show you that that sling I talked about earlier, that hammock, from underneath you can see that the yellow part is coming out a bit. So that's a cystocele. And you can see that the brown part is coming out here. That's a rectocele. And then the womb itself may just be coming out, and that's the uterus. Sometimes, unfortunately, all three can prolapse in some women. And there's another diagram here that's trying to show us. So this is normal. This is the front here, where the bladder, that arrow, the bladder is pushing into the vaginal wall. And that's the cystocele. And again, the bladder, look at that arrow, or the womb itself just comes out. And these are all the diagrams illustrating that. And this is what I said was the most dramatic one. This is actually the womb. This tip you are seeing here is the neck of the womb. That's the cervix. This is the whole body of the womb. The legs are up on either side, and it's just dropped out. Let me remember to mention that sometimes persons with collagen deficiencies or collagen based diseases like Ehlers-Danlos can also have significant pelvic floor prolapse. How do you now make a diagnosis of a pelvic floor prolapse? You must take a good history. You must ask this woman, why have you come to see me today? And sometimes I find that in my experience, this can be one of the most difficult conversations, especially depending on the race of the people. The Black and ethnic minorities, sometimes they do sign language when they come to see us. Good morning, what's the problem? And someone is pointing down below. They are not talking, but they are just pointing. And sometimes people come to the hospital with relatives. So as a doctor, you have to be discerning. Are you sensing that the body language is such that they don't want the relatives in there? So you're going to take a very good history. And this may sometimes involve sending somebody out or getting an interpreter. So either way, you are supposed to make that judgment call. What do they tell you? Are they telling you that when they go to the loo, do number 2, it feels like something is coming out? Or when they go and wee, it feels like it hasn't finished? The reason for this is that when the bladder is prolapsing, it becomes curved on itself. And if you think of the bladder like a big balloon that is expansile, if it curves on itself because a bit of it has gone into the vaginal wall, it means there's a drooping part behind it. And the weight, of course, is there. So it feels like the women have not finished emptying their bladders. Then you have to do a physical examination. And when I say physical examination, it's what most women do not like. They dread coming to the gynecologist because of this. But in this case, if I'm looking for a prolapse, I need to do 2 different kinds of positions to examine this lady. One, I would need to actually do the usual one, like when you go for your smear, you are lying on your back. So they do a finger examination, 2-finger examination, what you call the VEs. But Before you even go to the examination, the first thing is inspection. So that woman, you tell her to cough, you tell her to sort of sit up, and you sometimes just see these organs. When you cough, you raise that pressure, and what was hitherto not visible becomes visible. Or when you try and sit up, you can see urine sometimes may squeak and all of that. But then you use your steam speculum, which is the regular one everybody would use. The Costco speculum, which is the regular one everybody will use, the type that we use like a bed big when you go for your smears. But importantly, the most important examination is the one where you go on your side, on your left side, with your legs a bit flexed or bent. This is the one that's going to afford us to be able to see the prolapse a lot more, because understandably you are on the side, and that's called a Sims position. So for all of us listening today, please do not feel bad or ashamed when you go to the gynecologist and they have to put you in a different position to examine you because they are considering that you may have a prolapse. It is the only way to actually see that. You can't just see lying back and the conventional gynae position. You have to go into the Sims position. And sometimes we may need imaging. But I'll tell people that most times prolapse is a clinical assessment. We may take measurements. We know how we do that. We can do it with our fingers. We can call it mild, moderate, or severe, depending on what we find. And imaging is just an addendum, because sometimes people have adhesions, people may have bowels going into these, in which case it's then called an enterostele. You want to see properly what is there, so you may ask for some more imaging, scans or CT or MRI, depending. Or if people have associated cancers and you need to know what remedy you are going to work. So it's in those extreme cases you start asking for big imaging. Otherwise, just examining is okay to give you an idea. And sometimes when we examine in the office, understandably, because the patient is awake and because the patient may be tense, you may find out that what you see is a lot less than what you will see at operation. So, or at other management. So that's why we tell patients, try and relax as much as possible so that we can determine what the proper degree of prolapse is. But understandably, it's very difficult to relax on that couch at the time. Now, how do we manage prolapse? Importantly, up to 50% of prolapses can be managed by conservative approach. And if we take nothing away from here today, this is one thing I want us to take away. However, it is not just a magic wand. It's a long drawn out process. And when I say conservative, it involves everything. It's holistic, lifestyle modification. So you have to lose weight. You have to stop smoking to prevent that cough. You have to manage your asthma properly so that you are not coughing and having more attacks. You have to ensure that where you work, do you need to change the ergonomics? Do you need to get a particular kind of chair? Do you need to change your work sometimes? I know somebody who used to be a hairdresser in our community of Black and Afro-Caribbean. And she was having prolapse. She had to change. She had to change from hairdressing to dressmaking so she could sit down a bit more, because standing for eons was worsening her prolapse. So it may need some sort of radical lifestyle changes, and this is where support needs to come in. Partners, we need to give support. Family and family members will need to give support, because what we are wanting to achieve is the quality of life that is suitable for people. And this is why we shouldn't hide some of these things from those closest to us, because at the end, they're going to be the ones who would help us manage them. Still part of conservative, we have the pastries. We have a huge selection of pastries, and the pastries we'll use will depend on the kind of person, the age, the sexual function at the time. All of these will affect a choice of pessary. Whether the person has had a hysterectomy before or not will affect the kind of pessary we'll use. And pessaries do work. They do work. But what I found out is that most people look at them, or maybe because the clinic appointments are so short, sometimes we can't explain them quite quickly. And they go, oh, no, I don't want it. I don't want anything inside of me. Over the years, they have also developed them. They used to be very hard and firm, a lot more discomforting. Now they are all sort of soft and silicone sort of products. They are inert, so they don't react with most people's tissues. However, they would need to be changed every 3 to 4 months. Previously, we used to get new ones at each visit, but now there are some that we can reuse. We just wash them. And of course, you have the pelvic floor exercises. People can just go on the internet and read about pelvic floor exercises, but there are what we call directed pelvic floor exercises. And we have pelvic floor. We have physiotherapists who specialize in the pelvic floor. I'll talk about these exercises a bit more later, but just to suffice that this is something that you will have to do for life if you have organ prolapse. And if you don't have organ prolapse, for us women, it is something we just need to do. Consider it the way you go to the gym. It's something we need to do as well to help those muscles, those hammock muscles you saw. You know, sometimes you go to the gym and you do your weights. You get your dumbbells, you work on your biceps and your triceps, and they become firm. That's exactly what the pelvic floor exercises does for those hammock muscles. Then medically, you can have the use of medications. Significantly, in women who are beginning to lack estrogen, especially in the menopause, just giving them estrogen cream sometimes, or for those who end up being on hormone replacement therapy, having this in conjunction with lifestyle modifications can just cure their pelvic floor issues. Obviously, there are the surgical methods. There's what we call the anterior posterior repair, and there's what we call the hysterectomy. And you can do a vaginal hyst as well. So if the entire organ is just prolapsing, then you may need to take out everything. Like what you saw outside just now, they're going to do a vaginal hyst for that patient. However, there are patients who are also grossly unwell with a lot of other medical conditions, and they're old, and you may not be able to do any of these, and you will resort to just using pessaries for the lifespan of that patient. Anterior repair is where we go in, we actually push back the prolapse and tighten the vaginal wall. Or posterior repair is where we do the same thing for the back passage. We need to be careful when doing this, and that is why surgery is the last option, because sometimes you go there and you do these operations, and then for women who are still sexually active, you find out that you have narrowed things too much. They come down with pain during intercourse, and that can be a major problem. So the way you manage a patient will be to individualize that patient and manage holistically. If the patient young, will the patient still have children? If a patient is still going to have children, i.e. they've not completed their reproductive assignment, there is no need for you to go and do a pelvic floor repair, because in the next pregnancy, it's just going to prolapse again. So you need to really talk to your patients properly, see what they want, and explain to them. And in such cases, you find out that we tell the women to come back when they have completed their reproductive assignments, depending on how they want to, how many children they want to have, and explain to them that in the interim, they can be seeing physio and doing the pelvic floor exercises. As far as there's nothing life-threatening, prolapses in themselves will not kill anybody, but they will compromise the quality of life. And sometimes that can be worse than death, depending on how the person perceives it. So these are examples of pessaries. You have donuts there, you have gallon. That ring pessary you see there, that's one of the orthodox and really old ones. And people can have intercourse with a ring pessary in place. Now we go to the waterworks, the incontinence. Incontinence is involuntary loss of urine for no reason at all. You are weeing when you don't want to wee. You're not able to control the bladder, sometimes or all of the time. That's incontinence, simply put. And the opposite of that is retention. You want to wee, but you can't wee. I'll just talk briefly about that later. Now, what are the causes of incontinence? It can be overflow, it can be stress, it can be urge. And all this has to do with the pressures within the bladder and the sphincters around the bladder. There are two images before you now, showing exactly the same thing, but the one to the right of you on your screen, the way you're looking at your screen, you see that it shows the sphincters. It shows the sphincters at the neck of the bladder. In the first one, you can see that there's a lot of pressure, but there's an obstruction at the neck of the bladder. So it's not emptying properly. And then you start having overflow incontinence. Sometimes this can be from strictures where things are stuck together, or injuries from the past. Or sometimes it can just be when the sphincter is not working properly and it's just constantly tense. Now, the commonest one that people come in to talk about is stress incontinence, where you lift something, you laugh, you smile, you jump, you walk, you laugh, you dance, and wee comes out. You know, and it can be very annoying. People don't want to wee on themselves, but unfortunately, it's happening. And then, of course, urge. You can see the signs around the bladder, the third bladder. It looks like they are like electric shocks around the third bladder, if you look at it. And this is where you have oversensitivity of the bladder. It's where you have like too much firing of the bladder. And the bladder just begins to wee. You get to the house, you are not even able to put the key in the lock. The wee just goes. This can also happen when there is infection, when you have cystitis. But most times we just call it urge incontinence, or it can happen with neurologic disorders. You can have a mixed type of incontinence. And this is just a description of all those kind of incontinence. Pregnancy, childbirth, hormonal changes are majorly associated with stress incontinence. When estrogen leaves the system as in a menopause, it can really make people have this stress incontinence. Urge incontinence is when people are now just voiding when they don't want to. You wake up at night, you wee a lot more. The bladder goes into spasm with this kind of incontinence. And then, of course, the mixed one is where you have both. Overflow I've already talked about, and it could happen with stroke or in sclerosis as well, or with stones, physical blockage. I've showed that to us. And of course, functional. Functional is just when you can't get to the loo, not because your bladder is not functioning well, but because of something else, mobility problems. And people just wee on themselves. So what are the risk factors? Again, this time I've decided to group it to make it very clear to us. And these groups sometimes can also apply to the pelvic floor prolapses. You have lifestyle again, your drinks, your diet, your smoking, your obesity, your hobbies, your work. Please, caffeine in tea or in coffee is one of the greatest causes of incontinence. The first thing we tell our patients is lifestyle modifications. There's a leaflet of do's and don'ts. You don't need caffeine. You don't need anything that is carbonated. You don't need Coke, whether dietary Coke or the orthodox Coke. You don't need any type of those things. You need to cut down your smoking. You need to try and reduce your weight. What kind of work do you do? Is it where you stand like us doctors? We stand forever, and sometimes we can't even go for a wee. When you do that, you cause stasis of wee in your bladder. And the next thing is that it starts to grow microorganisms. You often have UTIs, you know. So these are predisposing factors to having stress, urinary incontinence, or any type of incontinence. Then, of course, there's physiological. I talked about pregnancy, I talked about menopause. And there's the pathological, the water infections, the neurological diseases where the nerves are affected, dementia. And then you have medication and cause. When you have the blood pressure medications, the diuretics, or when you have had an operation and we've inadvertently damaged some of the sphincters around the urethra, you know, these can cause incontinence. Sometimes as well, when we go and repair prolapse, especially when you repair the cystocele, you can have an unmasking of incontinence, and others are put not being mobile there. Investigation again is take a good history, get a bladder diary. Sometimes you do imaging, but importantly here, I want to talk about urodynamics. Urodynamics is where we go in and we study the pressures of the bladder and even sometimes the pressures in the rectum to determine what kind of thing is causing this incontinence. So there are specialist nurses or specialist physios that work together and create the urodynamic graph, which they send to us and we interpret. Management, again, is conservative. You can see that a lot of the management of all of these things it's actually patient-centered, patient-driven. This is why as healthcare providers, as relatives, we must keep these patients motivated and tell them, go on, you can do it. Bladder retraining is when you sit down with specialist nurses or physios, and they actually get you to use your minds to control your bladder. You are then told to go for a wee at intervals, maybe every 2 hours. Pelvic floor exercises is the big thing, and I'm going to tell us how best to do that. Of course, we have the pills that we can give to people, especially for those who have the urge incontinence. There are medications that you can be giving. Some of these medications can have side effects. They can make your mouth dry. Some of them can make you drowsy. But it's important to know that even these medications don't work overnight. Estrogen cream has been found to help people, or estrogen pessaries, when you give it, because sometimes that area is now dry in the menopause. When you give estrogen, you actually find that it helps to reduce incontinence. And of course, there is the surgical. The surgical aspect is where we begin to use different types of agents, different types of things to try and get to mimic the sphincter. So there is a sphincter around your urethra sometimes that actually opens when your bladder is full and closes when the bladder has been emptied. So we may do what they call the sling operation. Sometimes we may inject some agents into the urethra, bulkamid, but surgery should be the last resort. And we can do a lot with medical and conservative lifestyle changes. And obviously there was the hula baloo, I think I put that at the end, with the mesh, which we used to use to repair pelvic floor prolapses and sometimes manage incontinences. I put that at the end now, where we found out that the mesh was beginning to erode into some structures in some women, and it was all stopped. It was called the mesh, it was called the tape. If you think about it, it was a way to actually give support to those muscles. So there was a nationwide surgical mesh pause in the United Kingdom. And people have been working hard on both sides, both the patient and the doctors, to see how we can create better materials that don't erode into the tissues and cause problems, chronic pain, especially many years down the line. So in a nutshell, I have whizzed through, and those are the controversies. I have whizzed through topics that are actually big topics by themselves, and I'll be very happy to take questions. But before I just leave this law to take the questions, I want to actually appeal to the men in the house that in managing pelvic floor prolapses in women, their support is very much needed. In managing incontinence, your partner's support is one of the major things that can determine if a woman pulls through this with her psyche in place or not. Thank you very much.
Thank you very much, Loretta. Yes, you can stop sharing your screen. Thank you so much. That was a really interesting talk. He said it was a whiz through, but it was actually quite detailed. And we know that pelvic floor problems are one of those things that causes quite a lot of embarrassment, as you referred to in your talk. And so I like the last bit where you said that even the men that are here today should try and support their partners through these sorts of situations. So one of the questions I've had in the chat is, this lady's been told that by having cesarean sections, it protects her in the future. She's only intending to have 2 children. And if she has to choose between sections and having the problem where when you cough, you wee, these are her words, not mine. What should she do if she's only intending to have 2 pregnancies and there's such a risk of having pelvic floor and incontinence later on? Is that a valid choice?
This question is such a brilliant question, because many women actually come and make these inquiries. But let me tell us today that the fact that you are pregnant for 9 months in itself is sufficient to weaken the pelvic floor muscles even more than the actual delivery. So what do I mean? For 9 months, the womb is increasing with somebody else within it, sometimes 1, sometimes 2. And this hammock that you saw earlier is supporting all of this weight. Plus, you yourself would put on some weight. You're allowed to put on at least 3 kg. It's the rule of 3. 3 for the baby, 3 for the placenta, 3 for the liquor, 3, 3, 3. And you're supposed to have at least a total of 12 kg at least. And you're carrying this for 9 months. So that means that hammock is under stress for 9 months. And that in itself does even more damage than the actual delivery. So if you were to go and have a vaginal birth, it may not do as much damage as that actual 9 months of carrying that pregnancy. And don't forget that cesarean section itself is a big operation with its own adverse effects sometimes. And even in the process of C-section, sometimes some women's ureters can be caught. You may just, even bladder can be damaged. And that may then lead to what you are trying to protect, well, incontinence along the line. However, because we manage all patients, we individualize them, I would advise the lady that has asked this question to let the healthcare providers work with you and individualize you and manage you as you go along in pregnancy. Because if a woman had a very large baby, for instance, maybe over 4.5 kg on the scan, or a woman becomes diabetic along the lines in pregnancy, which we also know can cause large babies, or the baby is not positioned well, we then would envisage that there may be a difficult than normal, a difficult than usual vaginal delivery, which may then damage the pelvic floors. At that point, we can then say we would suggest that a cesarean section would be safer, because we don't want to have a dystocia, we don't want to have difficult instrumentals and all of that. So my final take on this question is, see how you go. Don't have preformed notions. Don't have mental blocks. See how you go, and then let the decision be a joint one between you and your providers.
Thank you. There's another question that has come, and it's about, she says she's not sure whether it pertains to this, but it's about surgery for prolapse. One of the things that worries her is the concern about future sexual function. And if she's managing, this lady is managing with pessaries, is surgery always indicated?
No, surgery is not always indicated. And this lady is a very sensible person. These are the kind of patients I love to have discussions with. I said when I was speaking earlier, one of my slides, that depending on the age of the patient within the reproductive timeline and the sexual function timeline, it's going to affect my holistic management of a patient's symptoms. And I did say that prolapses in themselves, herniations, if you want to use that word, of the pelvic floor organs would not in themselves kill anybody, but they will impair on the quality of life. And having good sexual health is of major concern to your gynecologist. So we are very careful. If you are using pessary, and I actually showed one of the pessary that I said was compatible with intercourse, and it's working for you, your partner is happy with that as well, please, you don't have to go for surgery, except things worsen. And the signs of things worsening is the pessary begins to fall out and the organs begin to come out a lot more. However, you can then change the size of the pessary as well. You may need to go for a bigger one. And it is important because a time will come when, if we went in and did surgery with the best of intentions, sometimes we take away too much tissues. And when that has been done, you can't come and attach them later. So you find that sometimes after some of these operations, we now are forced to start giving women dilators again to gradually help dilate and get the vagina to where we want it to be. But the sad thing is that a scar tissue is now there, which is not as expansile as the usual rugae of the vagina. So it simply means that if you are coping with pessaries and conservative measures, please, please keep surgery as a last resort. I must use this opportunity to address the myth of some women who say, oh, I want to go and tighten my vaginal wall for my partner so that he can enjoy, they don't even think of themselves, so that he can enjoy intercourse. Please, the best thing to tighten the vaginal wall is the pelvic floor exercises. And I'm going to talk about it now. You go on the internet and they tell you, how do you do pelvic floor exercises? Oh, it's you squeezing your muscles like you're holding back wee-wee. It is the cheapest exercise to do. It is the easiest exercise to do. You can do it anywhere. Set little alarms on your phone. It doesn't matter what age you are. You can start it from any age at all and make it a lifestyle. Because what happens is when you go and tamper with the vaginal skin, I see women who sit over all sorts of contraption, concussions, because they want to tighten the vaginal skin. They think that will cure the prolapse. No, you are just changing the pH of the vagina and you are probably scarring the vagina. If you take the muscles and you work the muscles, where's my dumbbell? I need to do this practically. 1 second. If I take this dumbbell and I do this every day, what happens? I'm going to have a hypertrophy of my muscles here. Okay, so that's what also happens when you squeeze those muscles like you're holding back urine and then you release them. But to do the targeted pelvic floor, you have to squeeze it ever so often. So you do quick ones and so fast ones, you squeeze maybe like 10 times in a row, squeeze, 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 and then you relax. Counts to maybe 30 seconds and squeeze, 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 squeeze again, and you relax. I'm doing it as I'm sat here. And that's what's going to cause the muscles to hypertrophy and actually lift that hammock. It's not the skin. So if we go there and start fiddling with the skin, we can cause more harm than good. Do your pelvic floor exercises when you have prolapse in, pessaries in, do them. And the best time to do your pelvic floor exercises, ladies in the house, when you are having intercourse, do your pelvic floor exercises. I don't want to go down the sexology route, but even your husband will thank you in the morning for a job well done.
Loretta. Well, you've answered one of the other questions that came into me, actually, about vaginoplasty, but you've answered that question. So I hope the lady who sent that question in has got a response, because that was one of her questions, that by going for vaginoplasty, will that help to cure her prolapse?
Not necessarily, and vaginoplasty is no longer free on the NHS. It used to be free ages ago. Not necessarily, it wouldn't cure your prolapse. But sometimes when some women have had episiotomies at delivery and it has healed with a lot of scarring, sometimes we may need to go there and release some tissues. That's completely different from prolapse. We may need to go there and even that in itself can cause more scarring and cause more problems. So make sure you go to your gynecologist for these things, not just any other doctor. For those of us that are not in the UK who are logged on to this program, make sure you go to a gynecologist.
Okay. This is a question from a lady who says that when she washes herself, she tends to put her finger inside her vagina and clean it out because she doesn't feel that she's properly cleaned. But she's been doing this for years and she squats down, but now she's starting to feel a bit of incontinence and she's wondering about whether this is as a consequence of how she's been cleaning herself over all these years.
It could be. It could be that in addition to her age, she's older now. However, our vagina is our own. You can put your finger in it. Okay, I advocate that you need to know what's going on down there. And this is what we are saying. It's not some sort of sacred temple that you yourself should not visualize or have any contact with. However, you must be careful. The vagina is a self-cleansing organ. It's a mini zoo created by God with its own special microbes. Nature has put that there to cleanse it. So most times we would recommend that you clean the vulva, which is the outer part, with whatever, a disclaimer here, I don't work for any of the feminine hygiene companies, but FemFresh has a good pH that doesn't alter the pH of your own skin. And obviously to wash away any odors. If you have to stick your fingers inside, please don't stick in anything other than water. Okay? And when you say you wash, if you've been washing with any of these hygiene products or soap, I think you need to stop that. Because what's happening is that you are getting older, estrogen is getting less in supply, and inadvertently, you are actually distorting the pH of the vagina and the urethra area as well. And that can actually lead to incontinence. So let nature do its job of self-cleansing where it's supposed to cleanse.
Thank you. There's another question from a lady who says that each time she has intercourse with her husband, she gets a UTI.
I know
Is that because of vaginal weakness or pelvic floor weakness?
No, not necessarily. I know some women who actually have these symptoms, and in literature, sometimes it has to do with a change in the pH, which seminal fluid can also cause. So, unknown to us, the seminal fluid itself has a particular pH. The vagina has a particular pH. Like I said, it functions optimally at that acidity, alkalinity balance levels. If something makes it to tilt towards being more acidic or tilt towards being more alkaline, there is an imbalance and the microbes can happen. And then that can irritate the whole area. So that whole area is the little outlet where urine comes out of on the vulva, and that can actually make some women a lot more, that irritation now makes them very sensitive, and it actually looks like, yes, they have a UTI at that point in time. So I would say it's worth seeing your gynecologist to actually also have an examination. And I've seen a very interesting case where a woman used to form stones. She didn't know. But after intercourse, because there is pressure from the vagina on the urethra, then you find that those stones actually were what was injuring her after intercourse. So it looked like she was always having a UTI after intercourse. So sometimes it's just worth seeing your gynecologist and actually mentioning it to the gynecologist and having a proper examination. But yes, we have seen that. Again, I want to ask, have you had samples taken and checked under the microscope of urine to make sure that it's a UTI? Because sometimes it may not be that it's bacterial caused, it may just be an alteration in the chemical balance.
Okay, she hasn't added that detail, but he or she hasn't added that detail, may I say. There's another question about the impact of HRT on the strength of your pelvic floor. Does it make it any better? So if you're approaching that time when we're saying that when you get to the menopause, does being on HRT make the situation better, or does it have no impact at all?
So with this question, I will speak directly to our Black and ethnic minority communities. In my experience, I find that irrespective of what is being said by the press, the data is available. We utilize the NHS the least for some strange and interesting reason. If we're approaching the menopause and we're having menopausal symptoms, which is a big subject for another day, one of the key things is that the ovary is shutting down, and the ovary is responsible for producing one of the major hormones of the female body. It keeps all our vessels and tissues supple. It gives them elasticity. You know, they begin to obey Hooke's law when you are young. It's like stretching a catapult. It comes back into place, or a rubber band. But when this estrogen starts to leave our bodies, when the ovaries are getting tired, they are being flogged by the brain and they're not producing estrogen anymore, what you begin to find is a loss of that elasticity. Now visualize that hammock I showed us earlier. What do you think is going to happen? It will start sagging, it will start tearing. It's not supple anymore. So yes, the menopause and the lack of the hormones will affect all our bodies, it will increase the prolapse. That's why you find that procedentia is commonest as we get older. The womb just drops. You know, it will affect incontinence as well, because that hormone is not there to keep anywhere lubricated. So if you were to go on HRT,
you've seen the comments.
I just saw that. If we were
those of you on Zoom, let me say that somebody's put in the chat that we don't use the NHS because we don't trust the staff. We're part of the NHS though, Carol. Both Loretta and I are doctors in the NHS.
We'll address that as well. So when you take...
Don't apologize, Carol. I understand where you're coming from.
Don't apologize. You are right. I'll address that now. When we take hormone replacement, just like the name implies, we are putting estrogen back in us, and it's giving us some suppleness and some leeway. However, this brings me back to using the NHS. You must go to your doctors, and they must take a good history. They must assess you holistically and decide, are you suitable for hormone replacement? And if you are, there is no harm in having some to help. But most times what I find is that in our Black and ethnic communities, we suffer in silence. We say blood of Jesus, it is not for us, but there is some help. You mustn't have it. Some women sail through the menopause. They don't know if anything is happening. Others will have all sorts of things, from prolapse to incontinence to UTI, hot sweats, and every interesting symptom under the sun. So if you come into that category, find out if you can have HRT and have it. And with respect to the NHS not trusting the staff, it is true. In obstetrics where I work, we had a release of data by Embrace, and we found out that Black women were 5 times more likely to come to harm in the NHS if they are Black. If they are Asians, they are 4 to 3 times. And if they are white, they are only 1 or 2. So 5 times more became a slogan for all obstetricians and gynecologists. And the NHS is trying to take steps as well. And we as a community, doing what CAHN is doing today, we are also taking steps. And I am saying here that it is your right to, 1, go to your GP. Sometimes we are so busy taking extra shifts because we want to send money back home to the Caribbean or Nigeria or anywhere, that we don't look after ourselves. 2, when you go to the doctors, and I always tell this to them when I take my mom, they are talking, the nurses are just talking. They don't even look at you to think, is he understanding? Is he understanding? They just keep talking. Please stop them. Tell them stop. And actually tell them, could you kindly slow down the pace of your speech? I can hear you, but I don't understand you. Sometimes I find that we don't speak out. And then 3, the NHS is now beginning to take measures as well. Like Auntie Ngozi just said, we work in the NHS, and all of us who work in the NHS, we can do our bits. I am in the diversity and inclusiveness group. You know, we can begin to tell them to increase the cultural sensitivity across board in the NHS. If we don't do it, if we don't also take our places at these tables, nobody's going to come and take it for us. And that's why these kind of programs are very, very necessary. How many of us are here now? 82. We could easily have been 500. Where are the rest of us? How many of us shared this link? Because you need to understand how a system works for you to use it as well.
Thank you for highlighting that. And as you say, this was precisely why the Caribbean African Health Network was set up, so that people feel empowered about looking after themselves, feel empowered to ask the right questions and say stop when they don't understand, and ask the doctors and the nurses to speak a bit slower. So thank you for highlighting that. And Carol, I want to say thank you for also raising that issue as well. That even though Loretta and I both work in the NHS, we understand the concerns that our communities have with the NHS. And that's why we're part of this program as well. Thank you. So there's a question here. I think it's a comment more than a question. It's how does the NHS look after their female staff, especially nurses and porters, moving and turning patients? I would say very badly, actually. That's my assessment of the whole thing. We don't look after our staff as well as we should. We don't pay them enough. And if there are any nurses on here that have voted to strike, I'm fully behind you. They are definitely not recognised as much for what they do. So slightly political and not health-wise, but I really feel that we need to recognise our nursing staff much better.
I want to agree.
You should agree, Loretta.
on Friday, was it Friday? No, on Thursday, I had only a ridiculous number of midwives to run an entire labor ward. I went to GAHN a similar problem. So one of the midwives came and said, please, can I just go for a wee? It was that bad. So the NHS is not treating all of us well. If I stand for laparoscopies, I get home and my back is sore. But then there's so many people waiting. There are waiting lists that you are wanting to cramp your own lists as well. I think these are difficult times across board. None of us are being treated right at all. But in all of this, you have to make that time for yourself. You have to say, I must take my break. There are times I just tell people, you have to stop now. We have to look out for each other. Go for your break. Or I just tell them, don't bleep me except it's a matter of life and death for the next 15 minutes. So you must put yourself first as well, because if you are not well, if you are not healthy, the NHS will continue. I realized that in 2017. I didn't go to work all of 2017 because I had major health issues. But the NHS ran. The world did not come down.
Absolutely. I know. That's just the way life is. So we do have to look after each other. There's a question here that I think I should answer. It's a question that's coming privately, but it's about a child, and many of you may know I'm a paediatrician. So it's about a toddler who has been using the bathroom, and if she doesn't get there within a short space of time, she wets herself. I would say don't worry at all. This is normal toddler behavior. You're doing well to try and potty train them. It's much more difficult nowadays because we have the availability of nappies that keep people very, very dry. People are less tolerant of children weeing around the house. So what we've noticed is that the age of children becoming continent has gone up over the last few years. But I wouldn't worry too much about it at all. For the lady who asked that question, this is normal toddler behavior. And she doesn't have incontinence.
Although in rare cases, though, they may have a UTI.
They may have a UTI. They may have a UTI.
Rare cases. So if you just get that checked out.
Yeah, but it's definitely not incontinence.
No.
Okay, I'm just looking through for any further questions that we have. We've had lots of comments about how interesting it is. You made the comment that there are 82 people watching, but we do have quite a number of people who choose to watch this on YouTube and on Facebook. So there are probably a few more people watching. And also, I know that people catch up in their own time because this is all recorded. There's another question about here about avoid. It says avoid carbonated drinks. You said during your talk.
Yes.
And so someone's asked, does sparkling water also count as one of these carbonated drinks?
It does. You know, I've never understood this concept of sparkling water. We're discussing it with the urodynamics nurse the other day. Why would you give your body all that carbon? Even though they say they've put some minerals, magnesium, and the rest in it, you just need water the way nature has made water. That's the truth. All these fancy things, we really do not need them. It counts. It's carbonated. You don't need it.
Okay, so this is just like how we've just talked about the 5 times more and the data that Embrace released. I think this might be a nurse or a doctor, I'm suspecting. However, I'm going to put their question. They said that they've been told that Black pelvises are quite strong and they're not liable to to prolapse as much as our white counterparts. Is this true or false?
It is true. It is true. When I was at Stoke-on-Trent, I was involved in a study in University of Kiel, looking at the tissues removed at the repair of pelvic floor prolapses, and we're looking at it based on race. We're looking at it under the microscope. Naturally, as Black people, we have the supporting protein of our skin structure, our muscle structure is a lot more. We have less of the collagen deficiency diseases as well. Ehlers-Danlos is not common in Black people. However,
Ehlers-Danlos, just to clarify, it is a disease of connective tissue.
Connective tissue disease, yeah. However, what we find is that we have more risk factors. And then when you are a migrant population and your innate diet and activity and lifestyle in your country of origin is varied from that in your host country, you become a bit more susceptible to certain things. But innately, yes, I would agree there's evidence to support that in the scientific base. However, you find that Black women may have a lot more children than the average Caucasian. In terms of lifestyle, white women may smoke more than Black women. It depends on if you are looking at on the continent and here, because all of us here are smoking, is cold, isn't it? But what I'm trying to say is that there are things in research that will confound the basic findings. We call them confounding factors. So whereas that statement is true, yes, I agree, but you cannot dismiss, and sometimes this is also the problem with the NHS. So we all read these things in the book. A Black woman comes and saying, down below, and everybody like, oh, why should she have prolapse? The other day, somebody was asking me at work, why would a nun have prolapse? She's not had any children. I said, really? But she stands for hours. Have you thought about that? So there are other things that can now skew those basic knowledge. So let's watch out. But yes, that's true.
Well, we're coming to the end of today. I'd just say that whilst we can consider this in a sense to, you said something about a host country. The reasons why we're having all these there, because this is now our country. And many of you will not have failed to realize that so many people in the media in the last 2 weeks have learned to say my name properly, because nobody made a mistake when they were saying Ngozi on the news outlets. I've never heard the name Ngozi said that many times before. So I'll just round up by saying, Loretta, thank you so much for such an interesting...
no problem, Auntie Ngozi. Sorry to interrupt you. Somebody just said something along the lines of our last question. He said, so is pelvic floor exercises effective in Afro-Caribbean women? I think I just saw something like that.
Okay.
Pelvic floor exercises are effective in all humans, including men as well. Thank you.
The reason why I almost hesitated to ask that last question, because remember, it's all individualized care. So even though they have these statistics, this is their population statistics. So there will still be many Black women who have prolapse. So I almost hesitated, but I just thought, well, they put the question in, and so
it's good. Yeah,
I asked it. Yeah. But thank you so much once again. It's been a fascinating talk. Lots of people have asked whether they can contact you directly for private consultation. Her details will be with the CAHN team, but thank you so much and have an excellent rest of the weekend. I'll hand you over to Sandra.
Thank you so much, Dr. Loretta, for a fantastic and insightful session full of valuable information. And thank you, Dr. Ngozi, for hosting our health hours. It's always a delight to have you. Just a few updates on our upcoming events. Next week, we'll be having another interesting discussion on hypertension and your heart. Our guest speaker will be Dr. Quincy Chuka. It's same time next week between 11 and 12:15. So please invite your families and your friends as we learn more about hypertension. Next slide, please. Another interesting program to tune into every Tuesday is our Healthy Hearts program. This program is focused on nutrition and healthy lifestyle. This Tuesday, we'll be looking at having a healthy, culturally focused season. This session will be delivered by Ashley Carter, so please endeavor to join us. Next slide, please. We also have available a culturally appropriate counseling service and family and advocacy service. So please, if you do know of anyone who needs some crucial support, then kindly give us a call or email us at help@cahn.org.uk if you wish to access these services. Next slide, please. We would like to invite everyone to the launch event of our Health and Wellbeing Hubs in Stockport and in Bolton. Our hubs are a one-stop center for our physical, mental, and emotional well-being services. Please come along to find out more about our health and well-being services. The dates and times are Monday, the 12th of December at the North Reddish Community Center at 2:30 p.m. and on Wednesday, the 14th December at the St. Paul's Church in Bolton at 2:30 p.m. For further information, please contact us on 077 100 22382. We would like to say a massive thanks to our partners for putting this wonderful program together. A big thank you to Croydon BME Forum, Rafa International Development Agency, the Royal Assembly Redeemed Christian Church of God, Black Health Initiative, and the Enfield Caribbean Association, and we have their contact details on the screen. In closing, I would like to say thank you again, Dr. Loretta and Dr. Ngozi, for facilitating this session. For myself and the whole team at CAHN, thank you so much, everyone, for joining us today. We look forward to seeing you again during the week and also next week, Saturday. Do look after yourself, keep warm, and see you soon. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.